thank you very much, everyone, for the very kind invitation. Sonal, thank you in particular. And thank you for bringing this up as a topic, because it forced us to do something that we've been meaning to do for years, which is update our numbers of the little fulminants. So I know you've got a bit of science fiction coming up and some other science and some precision work, so I'll just put this in. So the timing is quite good. I've put this in as one of those frontiers that many liver transplant surgeons want to aspire to. They're always wary about the really little kid. And if I have a 2-week-old waiting for a transplant and I have to do it the next day, that's the one transplant now that still keeps me quite anxious the night before. So we do our kids at the Birmingham Children's Hospital. We're what we call a high volume unit, doing about 40-45 kids a year. That's out of a total of about 250 to 270 grafts a year. I think this year's numbers will be less. We used to function at a very old hospital at Ladywood. That's where the program got going, and we're functioning now at an even older hospital because the Ladywood Hospital site has closed down. So we took over the general hospital. And the program got going through the 80s. We learned a lot through the late 80s and the early 90s. And then we were fortunate at that time to be right at the cusp of the developments of reduced size liver transplantation, split liver transplantation, intestinal transplantation. And we did the odd fulminant. But it wasn't until the late 90s that we would take on the really small fulminants. So I'm going to focus on mainly the last 20 years. Once you do a trawl through the literature, you find that there's quite a bit in terms of guidelines and the groups of patients, but there's not too much in terms of outcomes. Everyone just says that the outcomes are slightly inferior compared to what you see with acute liver failure in older children. So what is acute liver failure in little children? So I think the key couple of things are with or without prior liver disease, a coagulopathy, high levels of PT-INR, and the key thing is in a child that small, often understanding encephalopathy and eliciting it is almost impossible. So with or without associated encephalopathy. So that's transplantation is the only treatment available. There are lots of challenges, and we'll spend the next 10-15 minutes talking through these. Whatever's there in the results show that they're a good 10 to 20 points inferior to what we see with transplantation for children in general. And then there are key issues with respect to selection. Time won't permit me to do too much of that, but it's very important not to do futile or pointless transplantation. And the role of the pediatric hepatologist to exclude some metabolic conditions and to exclude treatable metabolic conditions are very important. So you're left with these following conditions that land up presenting with acute liver failure that require patients to be considered for transplantation. So some metabolic conditions, seronegative hepatitis or indeterminate hepatitis, herpes simplex virus as something. I want to talk about that because we now consider that as a contraindication, especially if there is multi-organ failure. And then the bread and butter is largely going to be neonatal hemochromatosis, and then a whole list of others like eosinophilic or giant cell hepatitis. So what are the big challenges? So that isn't a big hand of an anesthetist. That's an average-sized anesthetist's hand. And that's about as small as we have gone. That's the kid who's just around 2.1 kilos with quite a bit of ascites over there. We know that age represents a very relative negative predictive factor, and that's at both extremes of age. So at this extreme of age with the condition, it's a key factor. Making the diagnosis, I already mentioned earlier, is crucial to prevent futile transplantation. And then from the team, once they made a decision about transplantation, there are a few important points to understand. The incidence of this disease is very low, so the frequency is low even at a high volume center. There's big issues with patient size. There's big issues with graft and recipient weight mismatch. Obviously, huge issues with graft availability, even if you've got a situation where you can fast track living-related donors, because if the kid is very small, one of the two parents is potentially not a donor. The mother's usually not a donor in that setting. There's issues about vessel size, mainly about the artery and the portal vein. There's issues about the abdominal domain. And then two very important areas that have come on in leaps and bounds in the last 20 odd years, which is why the results are better now. The ability of our skilled anesthetists to be able to take very small babies through this operation. And then pediatric ICUs to be able to manage these kids pre-transplant, and then even the 2, 3, 4 weeks that some of them spend on the intensive care unit afterwards. Filtering a 2.5 kilo baby with renal impairment and metabolic acidosis is not the easiest. Likewise, ventilating someone for 2 weeks while a big, huge graft settles in is also not the easiest. And as a consequence, there are very few papers on outcomes. This is our donor pool. This just looks at age, and it just tells you, less than 5% of our donors are under the age of 17 years. So you have to innovate, and you have to innovate beyond what you would innovate for bigger kids. So a few surgical aspects. Some of it is practice. Some of it is what I have learned not to do. So I will assess the artery quite early. So the neonatal hemochromatotic liver, so that's the one right up there, is essentially a cirrhotic liver. Will often have a good, well-developed artery and a not too bad sized portal vein. You hardly ever see portal vein hypoplasia in this group of patients. And you could consider using the native artery, where we've got a very low threshold to put an aortic implant in, an aortic conduit in. And we put that conduit in right early on before the hepatectomy, just to keep the anhepatic period as short as possible, and also have to have the vessels absolutely ready for when the graft is implanted. I think it's very important that the hepatectomy is as bloodless as possible. A kid of 2.5, 3, 4 kilos does not tolerate 50 cc, 60 cc, 70 cc blood loss. We don't fiddle around too much dissecting it off the vena cava. We just put bicable clamps, cut it out. The kids tolerate the vena cava clamping very well, and you don't want to run the risk of losing blood from a very tiny hepatic vein, during a tedious dissection. It also keeps the hepatectomy phase very short. So within 35, 40, 50 minutes, usually the liver is easily out and ready for implantation. In terms of the implantation, big wide confluence of the hepatic veins, we use absorbable stitches. It's all pretty fine stuff, 5-0, 6-0, sometimes even 7-0. And we are very particular about pre-closure Dopplers just to make sure there is no compression on the vena cava. It's the easiest thing to compress a tiny baby's vena cava. The picture on the right is another one of our children, one of our first ones about 20 odd years ago, and that's his tiny little liver, 25, 30 grams at the age of 14 days, and he weighed, I think, 2.5 kilos at the time of his transplant. In terms of implantation, it's not very different compared to the left lateral implant. I think the key thing is just a very wide, triangulated venous outflow. And with a split graft, like in the living-related graft, you get a nice short hepatic vein, so the chances of it flopping over or kinking are very, very low. As far as the portal vein is concerned, it's not as bad as some of the very small biliary atretics. You almost always will get a portal vein. Sometimes you have to get down to the junction to put in an interposition graft. Essentially, the use of interposition grafts in this group of patients you think would be high, but it's actually not so high. And then again, we are quite careful about ensuring that there is some reasonable portal venous flow at the end. We try to keep the portal vein clamp time as short as possible because these guts get very edematous once you clamp the portal vein, unlike a biliary atresia patient. We also know that the smaller you go, the higher the incidence of post-operative portal vein complications. And here's just 3 series, a large US series, something from Mureo Kasahara, and something from our colleagues at King's College Hospital. And you can all 3 of them say the smaller you go, under 5 years in the US UNOS study, King's also the very small group and Mureo's group have a much higher incidence of portal venous problems in the very small children. In terms of the artery, I talked a little bit earlier on about the placement of the conduit. Again, the conduit usually comes from donors. The donors are usually young adults. And I think you've got to be very careful what vessel you use, because invariably the recipient aorta will be 3 millimeters, maybe 4 millimeters. And then the conduit vessel is at least that size, if not bigger. So it does have implications on flow patterns after the transplant. If you do have a good enough recipient artery, as you may get in some patients with neonatal hemochromatosis, then you're better off using it. If the arteries are good, we just use exactly the same technique. We don't resort to using any microscopes. We just use loupes and a conventional microsurgical set. They will all get a roux loop, because even if the duct is usable, the risks of complications are quite high. And also the ability to get into a small neonate's duct if you run into trouble post-transplant is very, very difficult. So a key area is the mismatch, size mismatch, and almost always these children will get livers that are effectively a large size graft. So I think we're averaging somewhere around 3.5% to 4% as the GRWR in this group. And then you have 3 or 4 options over here. The commonest option is to use an abdominal wall prosthesis, and we use Permacol here. We will subsegmentally reduce if we can and if we have to, and we'd use something like the Kazahara monosegment 2 graft, very infrequent. And then another approach is to tide over the first 4, 5, 6 days with a silastic patch and delay the abdominal closures. So all these tools are crucial in terms of taking some of these kids through. The shape of the liver is also hugely important, and I've just highlighted, something that Murray always puts up. It's the shape of the left lateral segment is crucial. The smaller the child is. So you want a nice, flat, slim left lateral segment that you'd get from a nice 50 kilo slim female donor, rather than going for a 65, 70 kilo male donor who's a bit chunky from anterior to posterior. So the shape is hugely important of the graft and decides whether you want to consider doing a hyperreduction or not. So as I said, Sonal forced us to do this audit. So you're going to be inflicted with this audit now. It's been done by Chaya Calgary, who some of you may remember from her days at Global Hospital. And Kej Bichi is one of our Italian surgical fellows who's prepared this. So it's literally hot off the press, and thank you again. So 220 odd acute liver failures, of which about half were under the age of 1 year, and only a relatively small proportion of these were transplanted, which again shows you there's a huge amount of selection there. And there's also quite a bit of patients that don't make it till a suitable donor organ becomes available. In terms of the diagnosis, the indeterminate group is the largest group. This is what we would also call seronegative. There's a few selected metabolics here: neonatal hemochromatosis, herpes simplex virus for 3 of these patients. And the presentation is pretty standard, lots of ascites, almost everybody with jaundice, and a few presenting with sepsis as the index event. Looking at some pre-transplant variables, a median bilirubin around 300, which translates to about 18 or 19 in milligrams percent, big transaminase levels, biggish ammonia levels, not so high creatinine levels as you would expect in a pediatric population, and with a PT that goes up as high as documented there, up to 180. Of these, approximately 45%, so approximately half were admitted to the intensive care unit pre-transplant, approximately a third ventilated before the transplant, and approximately a fifth or a sixth needing hemofiltration for fluid and acidosis management pre-transplant. So a very, very unique select group. So this is our experience over the last 20 years. The blue is the age, and the browns are the weights. And you can see there's probably a slight tendency to taking on slightly higher weight children as we have evolved. As I said, even on a busy unit like ours, we'll have 1 case every 10 or 12 months, and we'll be lucky if we do 3 over a 2-year period. A bit more on these patients who are transplanted. Median weight around 4 kilos, median age at transplantation 44 days. Good, nice long-term follow-up. A higher rate of graft loss, and this is long-term graft loss because there's a few chronic rejections there as well. And overall, we've lost over this time period 10 patients, 7 in the early period in the first 10 years, 7 in the early period of post-transplant within a 3-month period, and 3 late deaths. So let's look at some transplant variables, and the surgeons understand this language quite well. So a median weight around 4 kilos, a median donor weight around 50 kilos, giving us a donor-recipient weight ratio of around 9 to 10. So big jump over there. Looking at graft recipient weight ratios, you can see the means around 6 and the medians around 5.7. So very different compared to what you would accept for other children. You have to be very wary about the large for size graft situation. How high can you go? We've gone up to 22, as you can see, in terms of a graft recipient weight ratio, and in terms of donor weight, up to 16 times the difference between the donor weight and the recipient weight. Technical numbers: large use of arterial conduits, very few portal venous conduits, conventional left hepatic vein to confluence for the IVC. There's a few that were cable replacements, and these were 2 or 3 very small donors that were implanted. And then universally, the use of a RU loop almost always there. Higher incidence, again, numbers are quite small, only 30 patients. But if you just look at that, redoing the portal vein 3 out of 30 times, redoing the artery 2 out of 30 times. So not insignificant. So definitely looks slightly more challenging than you would get with your larger pediatric patient. The same thing is reflected also with early post-operative complications. Have listed the surgical ones here, the vascular ones, the biliary ones, and others. And you can see there's a few that are unique to this population. The compartment syndrome group, the development of collections, because each collection, even a 5 centimeter, 8 centimeter collection, is significant and will affect weaning and ventilation and recovery and the ability to close the abdomen. And then there's the odd bowel perforation. The good news is that these patients have not had previous surgeries, so you don't have to deal with the problem of making enterotomies because of previous Kasai operation. Closure, as you can see, primary closure only in 1/3 of the patients. Secondary closure in 2/3 of the patients, and then if you have a stage closure, you've got more issues in terms of impacting the stay. The bigger the discrepancy between the donor weight and the recipient weight, the more likely you are to have a staged abdominal closure. Other complications, it's important to put these two in. So I think the primary non-function we can probably leave out, because often it's a very sick recipient, because these patients almost always get very good livers. But one would have thought that this population would not get much by way of acute rejection, quite high over there. And then quite a high incidence of chronic rejection. These are obviously patients that are followed up into the long term, and quite a high incidence of bacterial and viral problems afterwards. At this age, again, they are much more prone to post-operative opportunistic viral infections that you would not see in slightly older children. Just a few tables now, just with the simple take-home messages. So 3 out of 3 HSVs died. So we now consider that a contraindication. So if you've got multi-organ failure, we will not take on herpes simplex virus. Pre-existing sepsis came up as a significant factor in the risk of mortality afterwards. And then one or two other factors played a role in mortality. The need for renal support, which again, you'd expect to mirror image what comes up with, in an adult pool or in an older pediatric pool. And then the higher the PT was higher at the time of listing in the ones with the worst outcome compared to the others. Talked a bit about chronic rejection earlier on. I think difficult to say too much about it, given that many of these patients develop these problems several years out, and there are other issues related to adolescence and compliance and puberty. So I think it's difficult to read too much into this. What's good is you can go against blood groups, and obviously which provides you a complete mix of patients, identical, compatible, and incompatible. We don't change immunosuppression protocols at all, and you can see there's no difference in the 3 groups, whether it was identical, compatible, or incompatible in terms of blood groups. Some logistic regression, again, busy slides, but just to show you that's all been put through a system. So the patient weight comes up as something. The donor age comes up as something, and it's interesting, whenever you do any analysis, donor age always comes up as something. In terms of graft loss, whether you get developed a portal vein thrombosis post-op had a problem, a biliary complication had a problem, and those who develop late chronic rejection also had a problem. In terms of predicting death, really nothing much came up in terms of the variables, with all the limitations of this being a very small patient and selected patient cohort. Similarly, also with other factors and the development of complications, not much of an impact in terms of being able to predict death. So if you look at Kaplan-Meier curves, so the curve on the left looks at all comers. You can see patient survival at 1 year is 76%, and of those that have survived, 87 have survived with their index graft. Okay, 5-year survival not very different. Overall patient survival is out there. The curve on the right looks at two groups of patients: a very small neonate, and then also the larger child up to 12 months. And this has excluded the 3 herpes simplex patients. And then these curves really don't look very different to what you achieve with acute liver failure in older children. And this is what we are seeing nationally with all comers undergoing elective pediatric transplantation. So not very different compared to what is your bread and butter of pediatric liver transplantation. So please forgive me if you've already seen this set, but this young man is a good friend of mine. He's a Christmas special of 20 years ago. I think we had no other surgeons in town, and the decision of whether one goes ahead with him or not. Both he and his mum were admitted with acute liver failure with giant cell hepatitis. Mother's liver managed to recover. He got a cadaver liver. He was 2.5 kilos. He was the smallest kid we did then. We've dropped down to, I think, 2.1 kilos since. He did exceedingly well, and then developed chronic rejection following a viral illness at the age of 13 or 14. He tried to keep that graft going, required a retransplant, got a retransplant from a living-related graft. That graft failed because of small for size, interestingly, because he had quite significant portal hypertension, and the donor was an older male donor. And then he got a cadaveric graft from a very small, full-size pediatric donor. So this young man is now 20 years out. We play an annual cricket match against him, and they've raised a huge amount of money for the liver unit. And right now, the last 4 years, these boys keep getting bigger and bigger, and they thrash the living daylights out of us. So in summary, I think it's a subgroup that's very interesting. Timely recognition of the condition and early referral is important. And this is a message that has to go out to community midwives, etc., in a kid that is floppy and not doing well post-delivery. Selection is vital. It's important to prevent futile transplantation. And I think time has not permitted me to go too much into that. We can discuss that. The listing criteria are different, so please be patient if another center lists a very small baby and does not tick your boxes that you understand as the King's College criteria for your adult patient or your teenagers. It's important not to do the patients who have significant contraindication, the mitochondrial disorders, and we would consider herpes simplex and multisystem involvement as an issue. Innovation is essential. Big technical aspects that we've covered: vascular, small for size, delayed closure, and hyperreduction. Graft selection has to be very careful because the margin for error is small. And then there are 2 groups of people that have really facilitated this, and I consider them the real heroes. So the pediatric anesthetists and the intensive care teams. The ability and the courage to take on a 2.5 kilo baby, manage them for 4, 5, 6, 7 days, and then for the 3, 4 weeks afterwards, some of them with filtration, with the big fluid shifts, is quite astounding. And that's the big difference compared to 20, 25 years ago. Higher incidence of early problems, so much more vigilance required, and the outcomes still are slightly inferior to what you see with pediatric transplantation. But the long-term outlook is fantastic with the Kaplan-Meier curves all flattening out. I couldn't find a picture of all our fulminant kids because we've never collected them, the small kids. But this is a group of our multivisceral recipients. So these are intestine transplant recipients. And the picture on the right shows the parents of these kids, and they are the real heroes. If I have 1 minute, I just want to promote our foundation. It's based in Mumbai. Sonal knows pretty much well about it. It's called Transplants Help the Poor Foundation. And we're happy to help patients requiring financial support for transplantation at any registered Indian pediatric or adult liver transplant center. Thanks a lot, guys.
Thank you, Professor Mirza, for that excellent overview. While we wait for questions to come on, there's one question on the chat from Patek Parekh. It asks for a subgroup analysis of data on patients transplanted before and after 6 months of age.
So the numbers are too. Can you still hear me?
Yeah.
The numbers are still too small to be able to look, but there definitely is an advantage if you pass the 5 kilo mark. Definitely. So, and I think any surgeon would understand that it's a completely different. It's a complete tiger country if you're under the 5 kilo mark, and under 3 kilos, it really becomes almost a lottery. If you know what I mean.
So I had a couple of questions with regards to technical aspects. Obviously, we've been guided a lot by your work, the work coming out of King's and from Professor Kasahara's group in the technique that we use. And are the techniques relatively comparable for, say, an acute liver failure versus a cirrhotic? Because in my mind, if you have an acute liver failure, there's not a lot you can do to augment portal outflow. It is what it is, because we do sort of patching of the anterior portal wall, for example. We tie up the coronary vein and we do the mobilization of the right and the left hepatic flexures, but the hepatic flexure and the splenic flexure. But there isn't much more we can do, right, in terms of augmentation, or is there?
No, literally almost nothing. But I think the key thing is, compared to the biliary atresia, you can always preserve the portal vein confluence. And the trick is to take it as wide as possible and produce the best possible funnel between the recipient portal vein bifurcation patch and what you've got with your donor liver. You can't influence the diameter of your donor left portal vein. That is anywhere between 8 millimeters and 12 millimeters, depending on the size of the graft. Because you select out relatively smaller grafts, you might be fortunate to get 8 or 9 millimeters. And you'll always be able to take the patch on the recipient from 3 millimeter, 4 millimeter diameter portal vein to a patch size of 6, 7, 8 millimeters. Always, almost always. And then no kink. I think they don't tolerate kinks well. And I would keep the portal vein clamp time as short as possible. And then lastly, in these small babies, I do not use a vascular clamp for the portal vein. I use the softest, tiniest, most gentle little bulldog that I've got.
Okay. No, that's great, because that's helpful. We also, the incidence of vascular injury with any of our stiffer, even bulldogs is actually quite high. So that's
soft. Venus spring bulldog is the best one.
Sonal, can I ask a question?
Sure.
Hi, Professor Darius. This is Matthew here. I'm a colleague of Sonal. Great talk. Obviously, this is an area which is quite challenging, and it's great to see the results as well. Could you just explain a bit more about the GRWR? And if I heard correct, you mentioned you went up as 22. Could you just expand on that?
So the GRWR in terms of what the weight of the left lateral would be. These grafts are then hyper reduced, but you're looking. I can't remember the exact figures, but you're looking at figures that are well above what you would normally accept. 6-7% is literally the norm. 7%, and you don't need much. A 200-gram liver will occlude the flow of a 4 millimeter IVC, even if there's the tiniest amount of pressure closing the abdominal cavity. And we've all made that mistake. So the mistake has been as recently as 4 or 5 years ago. So the threshold to close should be very, very different, because even the tiniest amount of the graft sitting on the cava can affect the outflow. And that just sets up a whole set of hemodynamics that you have no control over.
Okay. So you mean you had a larger GWR, but you then cut them down? Is that what you're saying?
Yes, we would trim them down. Yeah.
Okay. Fine. Thank you.
The other question, I think, intriguing about your data was that a lot of your patients were on hemofiltration, which sort of adds to the complexity a lot, isn't it? I mean, did you do any correlation between, say, vascular events and people who were on hemofiltration?
No. So these kids usually, it tends to be very short. It tends to be to tide over the period of acidosis or extremis that leads them to go to the ICU. We tend not to use any anticoagulation in these patients preoperatively, and then postoperatively we're always very wary about this group of patients. Anybody who's on a filter has a much higher risk of a bleeding diathesis. It's not so much thrombosis; it's more a bleeding diathesis that you're worried about.
And lastly, just one last question is, in terms of preference, do you have a preference between a monosegment or a reduced left lateral? What's your preference?
I think the reduced left lateral treats more the surgeon than the patient.
Yeah.
So I think if you really were to do a reduction because you can't fit something in, you're better off going it down to a monosegment. It does add an additional component to it because it's a double resection. So essentially, I think if you're fortunate with a left lateral segment, you can trim a little bit off the lower part and a little bit off the lateral part, but it doesn't add much. It doesn't add a huge amount. It doesn't change the chunkiness. You get one of those little mini burgers. That's what you want. What you want is a slim mini burger rather than a fat mini burger. And if the mini burger is fat, I think trimming it doesn't make. The only advantage of trimming it down further is you probably don't have the problem of underperfusion of the periphery of the graft. Because remember, they don't have a huge portal venous flow, and the graft they get will always be 3 times, 4 times, 5 times the size of the native liver. So perfusing these grafts is also not easy. Hence the advantage of having a nice aortic conduit for the arterial inflow.
Sure. Thank you so much for that, Professor Mirza.